What you did?
I did basically the same thing I did for the retinectomy, but in a slightly different way. I put a chandelier, and I used a bimanual way. I used forceps here and my cautery and cutter in the other hand. So I was able to roll the tissue much better in this situation, as you can see here, and then cauterize the edges. I was able to remove some pre-retinal and subretinal tissue which was PVR which I found. So this is just something I did which I normally wouldn't do. So in fact, I was able to even sort of address the other edges much better, which was looking a little rolled up. And then I was able to settle the retina even in the superotemporal region. And you can see here putting oil, doing oil PFCL exchange. You can see the laser edge of the retinectomy.
And before doing a very extensive retinectomy, once you started off the retinectomy, roll over the retina and remove all visible membranes, as Dr. Preetham and Gopal sir said. Subretinal space membranes are often ignored in the periphery, and those, in fact, if removed, loosen up the retina quite a bit.
Just one point, that when you're removing PVR membranes, as he would have thought he has finished everything, but then when he was putting the PFCL, he realized that the peripheral retina is still contracted, and when he tried to actually excise it, he actually found more membranes there. This is very, very common. It's not uncommon at all. And stretching the retina makes membranes become more easily visible. Means they pop up, the edges tend to get lifted up when you stretch it a little bit. When you're not seeing well the membranes, just put a bubble of PFCL and remove it again. Then you find that the stretching of the retina by the PFCL actually enable you to see membranes which are not as easily visible to start with.
Here was to just highlight the the usefulness of bimanual technique, putting a chandelier. In fact, I know some colleagues who are routinely using this kind of a chandelier to roll the edges of giant retinal tears also, and they find it to be more effective than doing it unimanually.
The chandelier position, I mean, one is this way in which you put a standalone chandelier either through a separate port, or there is a torpedo or a chandelier from different companies where you can either it stays by itself without any sutures, or some which need to be sutured like the infusion cannulas, or there are certain sharp fiber optics which you can just put into the infusion cannula also to make it into an illuminated infusion cannula, or there is a spade light pipe which you can pierce with a 26 or 27 gauge needle and just stick two ends of the fiber optics, raw fiber optics, and they act as chandelier illuminations. They are extremely useful tools for bimanual surgery, and should, in fact, in today's era, they should always be kept standby for all cases in the OR. Next case is by Dr. Ashish Vaidya.
So the second is the IOL which was dislocated, and you can see that the entire back was dislocated. So what we did was remove the IOL, and my choice over here was to fix in an iris claw lens, because I feel today that it's a very simple technique and gives us to good results. Now here I am trying to fix the claw. You have to be sure that the claws open up. I fixed in one claw, and now I'm going to try and put the second claw in. I think I'll fix the second claw also, and I leave the lens. And the lens is now lying vertical. It's got one claw which is fixed over here, and it's now dangling vertical in the vitreous cavity. So I have two questions. One is that what do you think of a iris claw versus a glued IOL versus a scleral fixated IOL from a retinal surgeon's viewpoint?
I have never done iris claw, so I just cannot answer your question straightforward. Yes, I have done not a glued IOL but a modification of that without the glue, and the usual scleral fix IOL technique which we do. I can talk about these two, the pluses and minuses. The regular scleral fix IOL is a all PMMA lens, large lens, is quite heavy, and is being slung with just two 10-0 Prolene sutures. So however wide apart the suture is outside the eyeball, over a period of time, it tends to cut through the sclera. And 5-10 years down the line, some of the cases which I have done 15 years back started to come back now with one side cut through or second side cut through, just hanging down, and all because it's a heavy lens basically. But for those 8-10 years, they work extremely well, no problem. And they require also a large cut to enter because 7.5 millimeters is the width of the optic, which is rigid. While if you use a foldable lens and exteriorize the haptics, you have the advantage that you can inject it through a small incision, less astigmatism obviously, and being supported by a Prolene suture, Prolene which is pretty thick, it is more stable and it is not heavy. But the downside is that these IOLs are not meant for scleral fixation. In the sense, the overall diameter this IOL is supposed to occupy is not supposed to go outside the eyeball, right? It's supposed to be within the bag. Now you ank the haptics out because you want to bring it outside. The junction of the haptic optic is kept under strain. So what is going to happen to these 10 years from now, I do not know. Unless somebody comes up with a scleral fix IOL meant for this purpose, where the angle of insertion of the haptic into the optic is different and the length of the haptic makes it convenient for you to bring it out and put it in the scleral pockets. But these are the two techniques I have done, with which I have experience. I think these are the pluses and minuses.
I think
Iris IOL
for that second technique, I think if you use a larger lens IOL, which is 13.5.
Agreed. I mean, you're trying to still compromise in the sense
still compromise.
that lens is not meant for that. That's what I mean. If you open the IOL, the haptic doesn't reach the eyeball at all and keep it outside. It reaches much far inside, right? Internal to the zonules, even the largest IOLs. But here we're just anchoring it this way and bringing it out. That's the problem.
So what I felt was that, rather than having a much longer surgical time, having a much shorter surgical time by putting a posterior chamber iris claw lens.
No, I'm sure it's a good technique. It's only that I have not done it. That's why I can't give you an experience.
Ashish, two questions. One is that you obviously changed your hands. So can you please describe to the audience how you did it in a very smooth manner without letting go of the lens?
Yeah, basically you have two techniques which you can do. One is that once you put the iris claw lens, you raise the lens up and you fix the claw in both sides. Either you can put your dialer from the same side as which you are going to do the fixation, or you can put it from the opposite side. So first I tried doing it from the same side, if you notice. Then you leave the dialer, switch the hands, catch it in the left hand, hold it steady, and then do it with the right hand. Now what happened over here, as you saw, was that the claw did not fix onto the iris, and now you have a lens which is dangling vertically. If the lens is fallen back, it's very simple to remove it. But now you have it dangling vertically, you don't want to damage the iris over here. And now what do you do is the question.
Actually, I am very regularly doing these lenses, all my FAK cases, and whenever the capsular support is not there, I do this, all nucleus drop and all.
Yeah.
So the problem, the problem which you faced in this case was because you have failed to see the dimple. See, whenever you are not seeing the dimple clearly, don't leave the lens. First thing. Second thing, when this thing happened to me, I just took my cannula of a visco or of anything or of a dialer. I went behind the claw of the left side. I slowly lifted that up, and once it was up, then I can say put that thing on the above the iris. Then I cleansed that lens and I put that dialer again to entangle that iris again. So the same problem I faced, but within 15 minutes you can solve this.
If it's vitrectomized,
Exactly. So that's exactly what I did. Can you just go to the next video?
Just one more comment, because I am doing these lenses very regularly. There is one problem which is not quoted up to until now, that is the glaucoma. You need to have these patients under your follow for your lifetime. Approximately half of the cases I am glaucoma without any, you can say, any explainable cause other than this. So
could
glaucoma
it be
is the
pigment
thing,
dispersion
artisan
because
lens.
of
Because in the cases of artisan IOLs,
could it be
I have
pigment
one
dispersion?
But
Pigment
even if
dispersion.
see, you are not able to see the pigment in the AC.
In the TRAB, TRAB meshwork, have you done gonioscopy for all these patients?
not.
So pigment
conical.
dispersion could be
Maybe
the cause,
thing.
pigment
Maybe the
blocking the trap mesh.
Maybe the thing.
But even if you fix it posteriorly, does
Yeah,
it happen?
all cases I do posteriorly only. I never place any lens in the AC. It is the crime as per me. See, I have so many cases. One I did in Amritsar, other I did in Agra, and my the IOL which I planted, there is no glaucoma. In other eye there is a severe glaucoma.
No, but
So
after doing a complete window
this is.
The pigments also go away, no?
There is no vitreous either in the AC or maybe I don't know really exactly what is there, but it is the incidence of the glaucoma in these lenses which should be, you can say, kept in our mind that these patients should be under our.
Okay, thank you. Point well made. Yeah, Ashish. Sorry. Let's. Yeah. Yeah. Please. Yes.
So I had a question for you. I had one patient, one-eyed patient with scleral fixation IOL. One suture cut through after a year or two, and the IOL was dangling down. How would you manage? Since he was one-eyed, I removed the lens and put ECL. How would you have?
Actually, an IOL inside the eye is much more easy to suture back than anything. You can even use the mechanical type of technique, but going through the pars placata area. That means you go with a long needle, and even if you don't engage the eyelet when you in the first sweep, you bring it out and take it back. So now there is a loop of 10-0 protein hanging inside the vitreous cavity. Under direct visualization, you can thread the 10-0 protein loop now around the haptic which is hanging, because you've got 3 ports inside the eye. If you want to add a 4th port with the chandelier, you can do that too, and have a forceps to lift up the dangling haptic. At the same time, make sure you're not pulling on the side which is still anchored, otherwise that will also snap. So then you lift it up and thread the loop which you have made into the eye around the haptic, and once it comes close to that eyelet, you just pull it up. It holds there. Once it is holding there, just try outside and turn the knot inside. At the same time, if you wish to, you can put extra suture on the opposite side, because now that this gave way, another 6 months from then, other one also can give way. Something like a lasso, but the whole lassoing is done anteriorly, because the IOL is already hanging from one side, right? Just lift it up and just thread it. That's it.